All right. Good afternoon, everyone. Thank you for joining us for today's genetic webinar entitled Red Flags of Genetics. This series is jointly provided by Texas Children's Hospital in collaboration with Baylor College of Medicine, Texas Health and Human Services, and the University of Texas at Austin, Texas Center for Disability Studies. Support for this presentation comes from the Department of State Health Services. Just a couple of accreditation and disclaimers here. The nursing accreditation and disclaimer slide has been displaying on the screen, and feel free to look at that. And if you are a social worker, licensed professional counselor, licensed marriage and family therapist, and licensed psychologist, and would like a free 1-hour CEU, this webinar has been approved for 1 hour by the University of Texas at Austin Office of Professional Development, School of Social Work. The views and opinions expressed during this presentation do not necessarily reflect those of the School of Social Work or the University of Texas, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the school or university. We'll be sharing how to receive CEUs for social work and nursing at the end of the presentation. We'll be saving time for your questions at the end of today's presentation, but you can submit your questions at any time during the presentation using the Q&A box at the top of your screen. Today's presenters are Amanda Gerard and Laura Buckner. Amanda Gerard is a certified genetic counselor in the Department of Molecular and Human Genetics at Baylor College of Medicine. She cares for patients in the General Genetics Outpatient Clinic and is the genetic counselor for the Skeletal Dysplasia Program at Texas Children's Hospital. Some of her primary roles include assisting with clinical evaluations, coordinating genetic testing, and interpreting and explaining genetic test results to families. Amanda is also involved in various research projects and publications related to rare diseases and participates in outreach work with multiple rare disease organizations. She is also a clinical supervisor for Baylor College of Medicine Genetic Counseling Program. Laura holds master's degrees in education, counseling, and rehabilitation. She is a licensed professional counselor and a certified mentor trainer in person-centered practices, the learning community for person-centered practices. Laura is experienced in educating others about family supports, state, local, and federal community resources for people with disabilities and their families, program development, and communication, sharing success stories to impact change. As a family member herself, she especially appreciates opportunities to work with families and those who serve families. While she says her most important degree is her MOM degree, her mom degree, having parented her 35-year-old son diagnosed at 3 months of age with a rare disease that includes IDD, autism, and chronic health issues. Laura says he has taught her everything she knows. Well, almost. Amanda is unable to make it to this meeting, but she did record her presentation. At this time, Chris Holder, our IT manager, will play the recording. If you have any questions for Amanda, feel free to add them to the Q&A box. Amanda will answer those in a follow-up email.
Sorry that I was not able to join today in person, but thank you for tuning in, and I'm looking forward to talking a little bit about red flags of genetics. So my name is Amanda Gerard. I'm a at the genetics clinic at Texas Children's Hospital in Houston. I've been here for about 8 years now, and I'm looking forward to speaking with you all today. I do not have any conflicts of interest to disclose, and I have a few objectives for today's talk. So the main kind of focus today, of course, is discussing common red flags for genetics referral, particularly in children of 0 to 3 years of age. There are a couple of kind of secondary objectives that go hand in hand with that as well. So I'm going to spend a little bit of time talking about the benefits of early genetic evaluation for care management, as well as resources for identifying and referring to genetics providers if you come across patients that you feel have some of these red flag referral that we'll talk about today. So I'm just going to get right into it. I have a lot that I want to cover in the next 25 minutes, so I'll move on to our first slides. So before I get into red flags of genetics, I want to talk just a little bit about what the benefits are of early genetic evaluation to patient care, because this question does come up sometimes, both from patient families or from patients and from providers. So sometimes I hear questions of, well, most genetic conditions don't have a cure, so what's the benefit of getting an early genetics evaluation or getting a patient in to see genetics early on, sure, if they may have a genetic diagnosis. And while that is true, many genetic conditions don't have a specific cure that kind of changes that genetic diagnosis. There's also a treatment plan associated with any genetic diagnosis. So having a specific genetic diagnosis can really help us and help the patient's overall care team tailor medical management and for their particular diagnosis, which can of course help improve outcomes. And the other thing I would say with this is, while it is true that most genetic conditions do not have a specific treatment associated with them, that's not always the case anymore. There are some genetic conditions like spinal muscular atrophy, achondroplasia, other genetic diagnoses now have associated treatments or medications or things like that are administered to patients in some instances. And so while this is said, there are many reasons why getting an early genetics evaluation is also quite beneficial in terms of treatment or in terms of the general medical management plan. Genetic diagnosis provide documentation and justification for support of more interventions, things like getting access to services, ECI, therapy resources, school resources, different things that having the documentation of a genetic diagnosis can be helpful for. And then it can also help provide validation to families. So often call out diagnostic genetic test results. Families really do feel a sense of kind of validation of finding an underlying cause for their child's developmental issues. A lot of families do really find it helpful to have that specific kind of answer as to why their child is having some of the issues that they're having. And it can also information about prognosis, what to expect in the future, what their child may need in the future, and connect them with other families who may have children or adults with the same genetic diagnosis. It really provide some kind of psychosocial support and validation for families. And then, of course, also having a genetic diagnosis can provide us with recurrence information. So it may help parents or even for the child when they grow up or other family members, what the chances are for other people in the family or other children between parents to have this same genetic condition. So I'll just present a brief case example to kind of highlight some of these points. So this is a case I just made up based on common reasons that we see patients in our clinic. So let's say that we have a 6-month who's presenting to clinic due to a history of a congenital heart defect, specifically a ventricular septal defect, as well as a cleft palate. And so we see the child in our clinic. We do a physical patient that we see, and we note some dysmorphic or unique facial features as well, those being a prominent nasal bridge and a bulbous nose. So if anybody on the call does have a background in genetics, there may be a genetic condition you're thinking of. If not, that's okay. That's what our job is. And so we had a specific genetic test that we recommended for this patient called a chromosome microarray, which essentially checks for extra or missing pieces of DNA or genetic material. And this genetic test did find a deletion or a missing piece of DNA on chromosome 22. So this result was consistent with a diagnosis of a condition called 22q11.2 deletion syndrome. This is a condition that previously you may also have heard DeGeorge syndrome or velocardiofacial syndrome. 22q is the more common kind of nomenclature that we use now, but you may also see it referred to as these other names as well. So this is a genetic condition that can be associated with a wide range of features. These can get defects and abnormalities at the palate, like we saw in our patient. But there can also be implications to other body systems. So just among many things, patients can have immune deficiency, they may have learning difficulties, psychiatric issues, and there can be impacts to other body systems as well. And so this was a very helpful result to know about for this because there are actually published guidelines for medical management for these children. They're published by the American College of Medical Genetics. And so I'm not going to go through all of this in detail, but you can see that both at diagnosis and then at various stages of life, there are specific clinical assessments and medical screenings that are recommended for these. So you can see just a few things listed here, nutritional and feeding assessments, history of infections, allergies, things like that, cardiac evaluation, which our patient had already had, but sometimes patients may not have come in with that assessment already, speech and language, learning, lots of different things that kind of had a direct impact on this patient's medical care. And so when we got this result back, we of course initiated several referrals. As I mentioned on the previous slide, there were screening recommendations that were started. We were able to use this diagnosis to provide rationale for starting therapy or ECI services early on, and particularly one of many genetic conditions that automatically qualify somebody as eligible for receiving ECI services. So going back to what I mentioned earlier on, this is one way that having a genetic diagnosis can help people qualify for specific services or resources. We were able to provide anticipatory guidance to the family. This patient, of course, was only 6 months, and so we were able to give them an idea of kind of as the child grows up, what's the spectrum of presentations or things that we need to kind of keep an eye out for in children with 22q deletion syndrome. We were able to plug them in with family support resources. There are several family groups that are out there for 22q, both locally, more in Texas, and nationally and internet. We're able to get them plugged in with some of those groups. And then we also sent parental genetic testing, and based on that, we're able to provide an overall low recurrence risk to the parents if they wanted to have future children. And so that's just one kind of case example of ways that genetic evaluation can be helpful and useful in the care of patients. Going into kind of the focus of today's talk, how do we find these patients? How do we know when a patient may need genetic evaluation or when that may be useful to a patient's workup? And so that's what I'll focus the next several minutes on, is these expert genetic evaluation in different ways that you, as somebody who may not be as familiar with genetics, can identify patients who may need further assessment. So one really great through the Mountain States Regional Genetics Network, which unfortunately is no longer funded, so they're not publishing new things, but they did publish this Red Flags for Genetic tool a few years ago. And it was based on a study sent out to parents of children with a genetic diagnosis, asking those parents about the first symptoms that concerned them about their child. So there were families who responded in both English and Spanish, and there ended up being over 500 symptoms that were tabulated and kind of incorporated into this tool. Of note, 89% of those responses were noted before 4 years of age, so relatively early on in life. And there were 6 categories on the next slide that the majority of these symptoms or red flags that were reported fell into. And so this is the tool right here that they published. They've posted on their website this kind of handout that they have used to provide to primary care providers and other people who may be involved in the assessment of patients who may need genetics referrals. So those 6 categories that they came up with were developmental delays, specific facial features or physical extra toes, cleft palate, unique facial features, large or small head size, different types of feeding issues, behavioral issues, failure to thrive or slow growth, and then issues with muscle strength and tone. So things like either floppy or low muscle tone, stiff or high tone, other types of neuromuscular issues. And they did have a few, you'll see at the bottom, that were reported that don't necessarily fall into one of those kind of umbrella categories, but that were relatively frequently reported as well. So seizures, hearing and vision concerns, things like that. Those are relatively common referral indications to our clinic. So I don't think the QR code, that's fortunately is still active, but you can go either on my previous slide or down here. They have the link to where you can access this tool if this is something that you feel would be helpful for you to kind of have on hand. And so this is just one tools that have been developed to kind of help with identifying genetic red flags in more of a primary or kind of general care or other types of settings. Another one I like is called the family genes mnemonic. And so this one starts out with and then just spells out the word genes, which I'll pull up on the next few bullet points. But the first letter or kind of part of it is family history. So if you see a family who says they have multiple people in the family, multiple siblings, multiple affected generations who have a similar health issue or type of health issue, be kind of a red flag that they may need further assessment. The G stands for groups of congenital anomalies. So 2 or more anomalies are much more likely to maybe be related to a genetic syndrome than a single anomaly alone. The E, extreme or exceptional presentation of common conditions. So things like a very early onset of a specific disease, earlier than you would expect it to present itself, very severe reactions to things like infections or metabolic stress, things that are usual for some reason. The N is for neurodevelopmental delay or degeneration. So things like developmental delay, regression, early onset neurologic deterioration. Developmental delay in particular is a very common referral indication to our pediatric genetics clinic. Extreme or exceptional pathology, so rare tumors, of cancers. We don't see that quite as frequently, I would say, on the ped side, but certainly in the adult setting, and there are pediatric indications as well where this can come into play. And surprising lab values. So laboratory values of biochemical tests that are very high, very low, kind of out of the extreme of what you would expect. So this is just kind of an hopefully easy to family genes that just tries to encompass some of the most common reasons why a patient may be seeing a genetics clinic or be referred to a genetics clinic. And so the last one I wanted to talk about was this proposed previously by a physician named Arthur Grix, and this was proposed as another way to quickly screen patients for red flags. So it's the rule of 2/2, so TOOUO. And some of these I think are relatively self-explanatory. So things like being too tall, too short, but a few of them I'll go into in a little bit more detail because I think they can use a little bit more explanation. So examples of too early or too young in terms of genetics red flags, maybe things like congenital sensory neural hearing loss, vision loss, cancers diagnosed at an earlier age, like oftentimes we say before age 50, renal failure, other types of things that you may think of as being more of adult onset that are having onset in childhood. That can be an example of when a child may need a genetic evaluation. Too many. One of the most common things we see kids for in our clinic are marks or cafe au lait macules, which you can see a photo of here, can be a red flag for possible neurofibromatosis type 1, which is a genetic condition. Too many fractures can potentially be indicative of a underlying genetic bone disease. Too many fingers or toes, or if they're just seeing too many specialists, like it has 5 different types of specialists they see, and you may be wondering, is there some sort of underlying genetic explanation or syndrome that can sort of tie all these things together? We also touched on a little bit on the previous slides, things like very abnormal labs, newborn screens, of course, if a child just has different facial features or kind of unique things that look a little bit different to you, that may be a manifestation of a genetic diagnosis. Abnormal skin head is too big or too small. Anything that kind of sticks out to you as being a little bit out of the usual in some cases may be an indication that the child does need further genetics workup. And then the last thing I'd touch on for this part of different ways to identify genetic red flags is this toolkit that was published with the goal to try to improve care for pediatric patients who have genetic conditions in the primary care setting. And so this was developed by a group called the Genetics in Primary Care Institute, which was a collaborative agreement of different organizations. And they published this toolkit that's linked down here in the bottom left to help primary care providers integrate genetics into their practice in various ways. So the full document is relatively long, which is helpful, but I don't have time to go through the whole thing today. But it essentially has 5 that are broken down into kind of getting started, how to collect a brief family history, ways to identify patients with suspected genetic conditions. So that is screenshotted and partially on the right side. They also have a pretty detailed list of potential clinical red flags and ways to identify patients who may have a genetic diagnosis. And then they also talk about how to provide appropriate care to these patients and coordinate care for patients with genetic conditions. So this is a great resource that not only addresses clinical red flags, but also addresses kind of other aspects of caring for patients or improving patient care in the setting. So this is a great resource if that's of interest to you. So that's everything I have in terms of identifying genetic red flags. I would say the overall summary is, there's not kind of one, unfortunately, tried and true way to identify every potential patient who could have some sort of genetic indication. But I hope 1 or 2 of these tools may have kind of resonated to you and stuck out to you as a way that you may want to think about that in your practice. Pick whichever one is most useful to you. I tried to have a few different examples so that people could pick whichever one makes the most sense to them in terms of the setting that they're working in or thinking about these things in, or whichever one seems kind of most useful and easiest to remember to them. So I hope those are helpful. The other thing I just wanted to touch on briefly, now that we've talked about, why is genetics important and I identify patients or people who may need a genetics assessment, is, what do I do after I've figured that out? I think genetics is important for this patient, but I don't know where to send them at that point. So I just want to be about how to find a genetics clinic or genetics providers. So one tool that I've linked down below, which is quite easy to use, is find a genetics clinic in the USA, which is through the American College of Medical Genetics and Genomics. And you can just go in there, type in your zip code or your location and genetics clinics that are located in your area. And it will tell you the type of clinic it is. So things like, is it telemedicine, in person? Does it focus on specific types of assessment? Like, is it genetics or pediatric genetics or different types of focuses? So that's a great tool for finding resources throughout the US. Another tool you can use is the Find Counselor link, which is through the National Society of Genetic Counselors. And it's kind of similar to how the ACMG tool works. It will give you options for in-person or telehealth, and it will tell you what types of assessment the genetic counselor focuses on. So that do they work more in a pediatric setting, adult setting, cancer setting, things like that. So this can also be a great tool for finding genetic service. The last one for us here in Texas is the Texas Society of Genetic Counselors, also has a list of genetics clinics that are specifically in Texas, and it can down into specific specialties so you can kind of find what is most applicable to your situation. It also lists out specialty clinics. So for example, us at Texas Children's, some specific clinics for certain genetic diagnoses. So for example, we have a skeletal dysplasia clinic that focuses specifically on kind of bone and skeletal related disorder. We have a neurofibromatosis clinic that's specifically for patients with neurofibromatosis genetics type 1. So if you are seeing somebody or know somebody with a specific genetics, you may want to take a look at those specialty clinic resources as well, because there may be a specific clinic that they could be seen in outside of just a kind of regular general genetics clinic. The other thing I'll say, is if you are unsure about a patient or how to get them plugged in with resources or kind of where to send them or how to do that, you can always use these tools at a genetics clinic or a genetic counselor and just contact that person or that clinic to ask for help. We certainly in our clinic, we get calls like that fairly frequently from primary care providers or other people who are kind of looking to get a family plugged in with genetic services and just don't really know where to start. So we can always help answer questions about, how to refer a patient, is a certain type of referral appropriate for our clinic, or are there other resources that may be more appropriate, things like that. So always feel free to call us if you're unsure. We know that genetics is a little bit not as familiar of a specialty for everyone. And so we're always happy to answer your questions about how to get patients plugged in with us or, other things that may be needed. So those are some ways that you can find genetics clinics either nationally or in Texas. And then these are just my references and links again to some of those resources that I listed. And that is all I have. So I'm sorry again that I wasn't able to join in person today, but if there are questions for me, I'm always happy to answer those. So you can reach me at this email, and I'm happy to discuss anything further or answer any questions that anybody may have for me. So thank you so much for tuning in. And again, feel free to reach out if more questions or anything come up from anybody. And with that, I will stop my recording. Thank you so much.
Chris, Laura, would you like to start sharing?
For everything I have to turn on, yes. I'm working on it. Hi, y'all. Okay, let's find, where's my, I'm looking for my PowerPoint and I'm not finding it. Share what screen, window, or tab? Oh, that's the email. That's Teams. How do I find my PowerPoint? Somebody? It's not showing up.
I think I have a copy. Would you like for me to share?
Yes, please.
Is it the genetic screening diagnosis?
Yeah, I think that's it. Yeah, thank you, because I don't know how to share it. I have it pulled up. I don't know how. Thank you. Thank you so much. Well, hi, y'all. Sorry about that little bit of technical glitch. My name is Laura Buckner, and I'm happy to be with you live today. I'm in person. And as Glad has told you, my most important degree is my MOM degree. My 36-year-old son just drove out the driveway to meet a friend for pizza, but he was diagnosed when he was 3 months old with a rare genetic disease. At the time, 36 years ago, they didn't have a gene marker for his disease, so they couldn't even tell us if we carried the gene or if we didn't. We found out maybe 10 years later when they did find a gene marker that we do not carry the gene. So I was glad to hear, and what was her name, Holly, say that, you don't have to have family history because a genetic condition can happen out of the blue. They used to call it a sporadic mutation. I'm not sure what they call it now, but it just happens. And, when he was diagnosed at 3 months, we were given a pretty grim prognosis, and it was very frightening. And so I want to speak to you about that perspective of being a very new mom or dad whose child is maybe showing some red flags. Maybe you're noticing that when you're with other people who have children the same age, their children are doing things your child is not. You're seeing things that they're not seeing. That can be a very scary and daunting situation. And so I want to talk to you about how to help families through that daunting, scary situation. We can go to the next slide, Gladys. Oh, you can just go on. I should have said that. So all of a sudden, maybe you've seen the pediatrician and they see some red flags that maybe you didn't even know were red flags, because that can happen. You know, you're a new parent, you don't know, but the pediatrician spots a red flag and says, you know, I'd like to see you get in for some genetic counseling. I'd like to see us do some genetic testing, and here's why. And of course, that will send a parent's head reeling. Go to the next slide, Gladys. So I just want to be prepared. I just want to prepare professionals to recognize that even if a parent has had other children prior to this child, or it's their first baby, regardless, being referred for genetic testing, or even somebody recognizing a genetic red flag, is often a total out of the blue, total shock. It can happen very unexpectedly. It might have been an unexpected possibility. There are some genetic conditions now, my son's is one of those, that can often be spotted in utero before the baby's born. So it might have been an expected possibility, but regardless, whether it's expected before the baby's born or within, a few months or even a year after the baby's born, all of a sudden there's references you hadn't expected. No baby book or pregnancy or child life book that I've ever read or found will prepare families for this. So I want to talk to you about what you can do to help them take important next steps. Because here's the thing, after they get into the geneticist and there's genetic testing, and let's say there's a diagnosis, which usually if there's a red flag, it often results in a genetic diagnosis. And many times it's a diagnosis you've never heard of before, or the parent has never heard of before. They're totally clueless about that diagnosis. But I just think you can remind families that that diagnosis is only a medical diagnosis. It is not the sum total of who this child is. I can remember calling my mother the night my 3-month-old baby had been diagnosed with this rare genetic disease I'd never heard of before, given a very grim prognosis. And I just was sobbing on the phone to her. And I said, but he looks so perfect. And she said, Laura, he's as perfect as he was yesterday. He's the same baby he's always been. You just have more information. That was powerful words for me to remember that it was just a medical diagnosis. It's not the sum total of who this little baby is and who he will be. So you can encourage families to recognize the disability or the diagnosis, the genetic condition, whatever, is just that. It's a medical diagnosis. And it's a critical piece of information, but it's not the sum total of who that child is. Next slide, Gladys. I want you to help families begin to recognize that that diagnosis or that disability label, that medical diagnosis, is what we call a passport to services. It opens the door to some important services. Holly spoke about if you get this genetic diagnosis, it can open the door to early childhood intervention services. That's a perfect example of, if you were to call ECI and say, I think my baby's having some problems, I'd like y'all to come out. You're not likely to qualify for their services, but you call them and say, my child's been diagnosed with XYZ, and they will be out tomorrow with services for your child. They'll automatically qualify with those genetic conditions or those diagnoses. So your diagnosis and that label, and by a label, I mean it could be cerebral palsy, it could be we used to call it mental retardation, now we call it IDD, intellectual developmental disability. It could be any of those, autism even. Those labels are just passports to services. They are not the sum total of who that child is or will be. And that is critical information for families to wrap their heads around. And the way I usually talk with families about it, I live in East Texas. I'm about an hour from the state line to Louisiana. And I go to Louisiana for an eye doctor appointment pretty regularly. I do not have to get my passport out to cross the state line into Shreveport. But if I were to leave the country into Mexico or Canada, for example, I would need my passport. So you pull your passport, that disability label or that medical diagnosis, you pull that passport out when you need it, but it doesn't have to come out every time you're talking about your child or every medical, every place you go with your child. And some families, especially when you're new to a diagnosis and you're seeing a lot of doctors and specialists who are talking about the diagnosis and talking about the therapeutic interventions, et cetera, you can get very sucked into that same way of talking. And you find yourself telling people at the grocery store about your child's diagnosis. And that's not necessary. It's really, more importantly, it's what you're telling your child about themselves. So I encourage families to think about what they're saying about that diagnosis or that label in front of people who don't need to know about it, because you're teaching your child who he or she is or might be. Next slide, Gladys, thanks. This was a quote I've always loved from William James. A long time ago, you can see, he said, "The greatest discovery of my generation is that human beings can alter their lives by altering their attitudes of mind." And our next slide, our attitude of mind was changed the night my son was diagnosed. We were so fortunate to land in the hands of a pediatric neurologist who saw our son on a Tuesday and knew what he had, knew the genetic condition he had. He could see from the signs in his skin, but he sent us for an MRI the next day to confirm it. And that night, on Wednesday night, he diagnosed our son with this rare genetic disease. And he sat with us in the hospital until after 10 o'clock at night. Bless his heart. He was we were so fortunate to land in his hands. But he told us, this child will be as disabled as you choose to see him. Wow. That put a lot of responsibility on my shoulders and my husband's shoulders as this kid's parents. It wasn't the disability that was going to change how we saw him. It was how we were going to choose to see him. And so I encourage you to say those same things to families, that the way they see that child is going to determine how disabled or not disabled he or she might be. Certainly the medical condition or the genetic condition is going to play a part in that child's life. There's no way around that. But I can remember for years, after being told this, for years, my husband and I, even now at 36, my son still has some developmental delay and some intellectual disability, but he has defied prognosis over and above, because we were told we would likely never walk or talk. He's done all that. He was a very fabulous high school, well-known distance runner in high school, varsity distance runner. But it started with us saying to ourselves, okay, is this normal 3-year-old behavior, or is this 3-year-old behavior exacerbated by this condition? And it usually was the second. It usually was what we were seeing out of our son was very typical of his age, but exacerbated or made more difficult or made bigger, made more challenging by the diagnosis. And so it was a really good way for my husband and I to think about this kiddo that we were raising, because many of the times, instead of just saying, well, he does that because he has autism, or well, he does that because he has this or that or whatever. No, that's typical behavior for a child his age, or maybe a little younger, but it's probably made bigger or made harder or made more challenging by that medical diagnosis. Next slide, Gladys. So what I encourage providers to do always is provide knowledgeable, up-to-date, that's a really critical piece, up-to-date, reliable, and accessible resources. And I say up-to-date because our pediatrician got word about my son's diagnosis. He was a lovely man. We loved him. We kept seeing him for years, but well-intended, he sent us some information in the mail about our son's diagnosis. And I know he meant well, but what he sent us was outdated. And he didn't know it because it's a rare disease. You have to know about the disease to know much. And he didn't know that what he sent us was not up to date. Fortunately, our pediatric neurologist that diagnosed my son also told us, do not read anything unless it's by Dr. XYZ. And he named the doctor, who at the time was the international expert in my child's diagnosis. And I remember reading the stuff that my pediatrician sent us and just having near panic attack because it had sounded so very horrible, and then thought, oh, wait a minute, let me see who wrote this. And I went back to the author, and it was not Dr. XYZ, and I threw it away. I never looked at it again because it was out of date information, not on purpose from the pediatrician's perspective. He didn't know. But before you send parents down a trail, make sure your information that you're providing them is really up to date, especially with genetic conditions. The study of the human genome has exponentially exploded in the last 10 years. They know things they did not know 10 years ago. In our 36 years, they know things way more than they knew 36 years ago. And so things are changing almost every day in the genetics world. And you want to make sure that the information you're putting out there is current and it's up to date and it's reliable and they can get a hold of it. Don't send them to medical journals that they can't get into because they don't belong to the society or whatever. Get them resources they can access, that they can understand, and that are reliable or up to date. Next slide, Gladys. Some connections that I encourage you to connect parents with, because, and Holly spoke about this, connecting parents with other parents whose child has a similar diagnosis is critical, especially if it's one of these like mine, a rare disease. I know people all over the country with my son's diagnosis, but I don't know anybody in our community because it's rare. There's not anybody that we know of. But because we're a part of an organization that, for my son, it specializes in that diagnosis, it's connected us with people all over the world who are dealing with that diagnosis. Texas Parent to Parent isn't diagnosis specific, but it is a parent-friendly organization run by parents. And you can, they have regional and state conferences every year. You can often call, a parent can call them and say, my child's just been diagnosed with XYZ. And can you connect me with anybody who knows anything about that? And they will have often on their radar another family who has that same diagnosis and have been trained to talk to other families. They're not just sending you out in the blind. They can connect you to people who know about the disorder or the diagnosis. They can also just connect you with parents who are living a similar journey, because all of a sudden you find yourself on a path that a lot of people around you are not on, and they don't know how to help you. But parents who are on a similar journey, even if it's a different diagnosis, maybe they have had to navigate this SSI, Social Security. Maybe they've had to navigate that system. Or maybe they've had to navigate the local early childhood intervention services or the local Medicaid services. They're the ones who really know what you need to know. So connect families with families to the best of your abilities. I know medical professionals are very limited by HIPAA restrictions, but I will tell you, I have medical professionals regularly who will say, can I give your name to another family that has a similar situation? Would you mind if they call you? And I can give them permission, and then if they're not breaking a HIPAA restriction, and they connect families with other families who know what's happening. Next slide. This is a website that's really helpful for children from birth to 3 all the way up past 18 years of age. It's called Texas Project First. It is funded by the Texas Education Agency. It's written by parents for parents. I have written pieces on this website, and I've been a part of this website since it was started 25 years ago, I think. 20 years ago. It's been on there a good long while. And you can see it in those blue buttons. We call them age range buttons. If you're dealing with a child 0 to 3, you would send parents to the 0 to 3 page because there's information. There'll be information there about early childhood intervention services, Medicaid services, etc. Things that parents need to know when their child's in that age range. Once a child ages out of early childhood intervention at the age of 3, they automatically qualify with a diagnosis like we're talking about. They'll qualify for special education services in their local school district. So that age range button 3 to 5 would be a perfect fit for them, etc., all the way up the scale. Oh, we moved. Okay, thank you. ECI, you can go to the next slide. ECI, we call it ECI lovingly, but it's called Early Childhood Intervention. It's a statewide program within the Texas Health and Human Services Commission, and it's specifically for children, families for children who, from birth to 36 months of age, who have developmental delays, a known disability, or even known medical diagnoses that could impact their development. A child doesn't have to show a developmental delay to qualify for ECI services if they have a medical diagnosis that may impact, and Holly spoke about that. You call your local Intellectual Developmental Disability Authority, we call them LIDA, we used to call them MHMR. You call that local authority and they can refer you to the local ECI services. Next slide. The Medicaid waivers, I don't care what you know about them or what you don't know about them. You need to get people on these lists and send them to this link that's in the slide first. If you go to the Texas Health and Human Services website, with all due respect, it's not written in as parent-friendly language as many parents need when they're brand new to this diagnosis and this new system of dealing with a child with all of a sudden unexpected or challenging situations. If you go to this website, Navigate Life Texas, there is a link and this link is it, that takes you to a page specific to Texas waivers that are explained in parent-friendly language. In fact, they have a video of a parent talking about them, explaining what they are, why you want to be on the list. And the reason you want families on the list as soon as that child has a diagnosis is that Texas has a very, very long list of people waiting for services. The typical wait is 12 to 18 years. So if you're dealing with a new baby, 0 to 3, you don't want to wait till that child's 15 and the family says, we're going to need more help, because then they're 12 to 18 years behind the 8 ball. You need to get them on the list as soon as you have a diagnosis. Next slide. You do not have to qualify to get on the wait list. The state calls it an interest list. I call it a wait list. You do not have to qualify to get on that list. You do not have to know what services a child is going to need, or even if they will qualify to get on the list. The only information you're going to need to provide is the child's name, date of birth, social security number, some demographic stuff, and a brief questionnaire. That family will be given an ID number. They have to keep track of that ID number, because if they lose it, and if they say they move or their contact information changes, they could fall off the list, and we don't want that. And the website, yourtexasbenefits.com, is operated by the Texas Health and Human Services System, and you can use that website to keep up with your ID number, update any information, and keep track of details, even like where your child is on the list. Next slide. These are some helpful phone numbers in your slides for how to get your child on that interest list for services. So the first number is for, these are all Medicaid waivers. They're just called different things. And depending on the Medicaid waiver determines who qualifies for it, how you qualify, et cetera, who served under it. So we have Medicaid waivers called CLASS, Community Living and Assistance Support Services, deaf, blind, medically dependent, children. There's all these labels, but if you go to the website that I referred you to on Navigate Life Texas, it will explain those waivers, explain how you qualify for each of those waivers, what services each of those waivers can provide, etc. Go to the next slide. And so this is what I tell professionals about those Medicaid waiver lists. You definitely want to give families this information in writing, because they're already being inundated with a lot of verbal information from medical professionals and therapists and whoever else is involved in this situation. And it's a lot to process, and they're not likely to remember it all. So do give it to them in writing, but even bigger, suggest that someone else make the calls for them or with them, because it's likely to get lost in the pile of paper and lost in the pile of information that's going into their heads and sent them reeling. even better, make the call with them. It only takes about 10 minutes. Make the call with them, and then you know they're on the interest list, and encourage them to update that information annually on the yourtexasbenefits.com website. Because again, if their information changes, they could fall off that interest list, and we don't want that. Next slide. And when you're qualifying for services, there's all these different when you go to yourtexasbenefits.com, there's all these different links for different services you can apply for. But the services we're talking about specifically for Medicaid waivers is the one that's circled, called long-term care services. And by long-term care services, we're talking about perhaps it's respite care, give the parents a family a little bit of time away from home while somebody takes care of their child for them. It could be attendant care, somebody who's providing some assistance to the child, even as a teenager or young adult. My son is on a Medicaid waiver and gets attendant care services. It might be some certain kinds of therapies. The class program, we were on the class program for a while that provided horse therapy, music therapy, physical and occupational therapy, speech therapy. Other Medicaid waivers may not provide the same kinds of therapy. So again, you want to look at what it provides and what that child is going to need. But that you don't have to know all of that information to put your name on the interest list. Next slide. So do have a clear conversation with the family about the financial restrictions that are involved in Medicaid waivers and Social Security benefits. It applies to both. Medicaid waivers are state funded, Social Security is federally funded, but either one of them, the child is limited to $2,000 in their name for life. If they ever get $2,001, they could lose their benefits. So, you have, and this is a hard conversation to have with families, but I encourage families not to set a bank account up in that child's name, not to set up a trust fund in that child's name. A special needs trust is a different way of going about that. There are ways to help the child save money without impairing or interfering with their benefits. And parent to parent can give you Texas parent to parent can give you a lot of good information about all of that. But bottom line, you want to keep that amount of money in that child's name under $2,000. Next slide. And lastly, I'll just say, remember, nobody has a crystal ball. The best geneticist in the world, the best pediatrician in the world, the best neurologist in the world, they have a ton of good information, but they do not have a crystal ball. Their job is to paint the picture that's possible. And that might be a really grim picture. It certainly was when our son was diagnosed at the age of 3 months. It was a very grim picture. But our neurologist would do us no favors if he painted a picture with rose-colored glasses and then it didn't turn out to be. We had to know what was possible. But next slide. The family's job is to become an expert on who this child is outside of the diagnosis, to believe in what's possible, what this child loves to do, what they're good at, what they're interested in, and to have hope and work to develop those interests, those skills, those talents for this child in their future. Next slide. So help families become experts. You want to listen to them because they're scared. Often they're overwhelmed. They're scared to death. They're worried. Listen to them, value their insights, their observations, their questions, because they're the ones living at home with this baby and seeing things that you may not see in the office visit or in the medical appointment. You want to teach them what they need to know about this diagnosis. And lastly, commend them for what they're doing well. Often when you're in this situation as a family member, you can get overwhelmed by all the things that you're not doing very well, or you don't think you're doing very well. You can get overwhelmed with the fears and the worries for the future, the things that you've missed, and you lose sight of the things that you're actually doing well. So I encourage professionals to let the families know what they're doing well and commend them for that, because you remind them of that they are capable parents and that they are doing a good job and that they're dealing with a situation that a lot of people have never dealt with, and they're doing it well. Next slide. And cultivate hope. We will never know what the future holds for these children. technology, and my son's 36 years, technology has exploded, right? I remember saying to the second grade teachers when my son was in the second grade, we went to an IEP meeting. I could see that his math skills were not going to be good, and they're not. He still, he can count to 20 consistently many times, but not always. He doesn't count money well. He can spend it like nobody's business, but he doesn't count it at all. Change has no concept of change. And I remember telling the second grade teachers, I can see his math skills are going to be poor. I wonder if we should teach him a calculator. And they looked at me like I had grown a second head and then said, but Laura, we're afraid he'll become dependent on it. Okay, who doesn't have a calculator on their phone? Who knew all those years ago, 25 years ago, that we would have calculators on our phones? Find a cashier that knows how to count change. They don't, because we have computers who do all of that now. My son can't spell worth a flip, but you know what? Siri can spell it for him. We have word prediction software. Technology has changed the world for people with disabilities in ways we could never have imagined 35 years ago when we started this journey. We don't know what the future holds in the next 35 years for these kids. So cultivate hope. Let the parents know there's lots to hope for. And the last thing I'll just tell you is that if I didn't answer a question today, you have my email, and I'm happy to answer a question later. But I think we have a few minutes left if I can answer any questions now, if there are any. Thanks. Thanks for being here today.
Thanks, Laura. Yeah, if you have any questions, feel free to add them in the Q&A box.
Oh, thank you. I see the hands clapping. Thank you. That's very helpful. We appreciate that. You know where we are. If you have questions, look us up, email us your questions, let us know what we could do to help in the future. And thank you for what you're doing. Thank you for being here today. I'll turn it back over to you, Gladys.
Well, thank you very much once again. We're grateful for your time and for everybody's participation in today's webinar. If you're viewing live today, within 24 hours, you'll receive an email with survey links for both the social work and the nursing evaluations. And this needs to be completed to receive credit. Once the survey is completed, you'll receive a certificate of completion within a 48 to 72 business hours. If you're viewing a recorded version of this webinar, this session is not eligible to receive CEUs from the recording. If you have any questions about this session, please feel free to contact me, Gladys Pryor, at gladys.pryor@bcm.edu. This is the last webinar of our 2024-2025 program year, but we will share information about our 2025-2026 program year in the fall. We hope you can join us in the future. Once again, thank you very much for your time, and this concludes today's webinar. Have a great afternoon and rest of your summer.
And thank you for your kind comments. Bye.